Yeah. How many copies does it have to be actually? One?
No.
It was cheap.
Yeah, there'll definitely Parkinson's. It's very common. Most Parkinson's patients, they die once they, let's say they get old, right? Because they always aspirate. That's when they get admitted to the hospital. They aspirate, from just eating, at home, and then they go into pneumonia, and then they get septic, and then that's it. No, they can't. For shock, yeah, I can do that. Mhm.
Is yes?
Yeah.
Okay.
Where were we now? We finished cancer. Okay. All right, let's continue. For head injury, we have intracranial pressure, increased intracranial pressure management. So it's collaborative care. So this will cover both signs and symptoms, meaning recognizing. So the patient could be a stroke patient, could be a head injury patient, and because both will have increased ICP. So you're required to recognize what are the signs, and then interventions. So interventions from positioning to oxygenation to temperature regulation to medications. Any questions on that? For instance, so what do you do for the patient's oxygenation level? How do you manage it? Knowing that hypercarbia will do what? Vasodilation. So what do you want to do?
Give oxygen.
Okay, there you go. Make sure the oxygen levels normal or high.
Can you highlight where we are? I lost track.
Right here. Then prioritizing signs and symptoms of increased ICP to report. So what are what's the most crucial? Okay, so you mentioned level of consciousness. So of course, the Glasgow Coma Scale score, the lower, then the more priority. Regarding that, what are those three signs again of Cushing's triad? And remember, the Cheyne-Stokes respirations is also one of the triad in some authors. And so I covered already the measures to prevent. So this, when it says prevent, that can also be an intervention, okay, not just for prevention. So positioning, what's the positioning again? 30 to 45. Because these patients that say in severe head injury, they're intubated, right? So therefore, what do? You have to suction, and suctioning causes increased ICP. So, okay, make sure you follow the checklist for hyperoxygenation. So right after you withdraw the catheter, you apply suction on withdrawal, right? What do you do next as soon as the catheter is out? Oxygen first, and then rinse the catheter, all right? Mannitol administration. So what did we say about mannitol? How do you draw it up? Filter needle. What is the effect of mannitol on blood pressure? So therefore, what should be assessed before giving it? Knowing that blood pressure must remain blank on head injury or stroke patients. Blood pressure must be high. What's because why again? Okay. When you draw it up, exposed to the atmosphere, it will cause crystallization. So must be drawn with a filter needle. Correct, because this will drop blood pressure. So let's say my patient's blood pressure's already 120 over 79. Is it safe to give mannitol?
No.
Oh, because remember CPP, we need the blood pressure high, at least 140 and up. As long as it's below 185 over 110. What is this ICP monitoring equipment we're referring to here? Intraventricular catheter. Priority assessment after TBI? Just like, okay, so yeah, airway. So this was also found under spinal cord injury. So same principle, ABC. And then if it's the spinal cord injury as well, then you stabilize the spine using a rigid collar and then look for other injuries, etc. Cerebral edema, which causes increased ICP. So what drug is used to decrease cerebral edema? Mannitol. And what steroid can be used? Dexamethasone. What happens to the patient's sodium levels usually after stroke or head injury? Does it go up or down? Sodium levels. Down. Okay, so there's something called salt wasting syndrome, right? So can that exacerbate cerebral edema? Yes. What else are your responsibilities when your patient has cerebral edema? You institute what precautions?
Seizure.
Okay, seizure. And what are those activities? Seizure precautions include what equipment must be at the bedside? And what should you have? IVS. Some hospitals still pad side rails, but some do not. But very important, at least you should have suction and oxygen. Very important. And IV access, don't forget. What if the patient keeps pulling out their IV access because they're confused?
One-to-one.
Leave it.
One-to-one.
Okay, so that what happens in real world, okay? They pull out IVs, anything that's uncomfortable, they pull that, okay? So make sure they always have access at all times. Autonomic dysreflexia. Prevent and manage. So how do we prevent this complication in spinal cord injury patients?
We make sure. We now retention.
Sorry.
We now retention.
So you assess. Okay, check what are the two most common triggers? Bladder or bowel distension. Okay. What else?
Skin pressure.
Pressure injuries. Okay, so also any restrictive clothing, a tourniquet somebody left, or a tight, a tight ID band, for instance. Okay. So you have one of them, well, technically it's not math because it involves an assessment as well, but yeah, you still total, so technically it's math. And you're not allowed to bring any cheat sheets, so you should memorize the Glasgow Coma Scale. And it says interpret the results. So the lower the number, what's the threshold for intubation? What number? What score? 8. Okay. So usually when they reach 8, that's deep coma already. So can they still protect their airway at this point? Okay, so they have to be intubated. So that's your job, right? To initiate it because you're the ones assessing the Glasgow Coma Scale all the time. So patient scores 8, that's deep coma, call the physician, notify them of your results, and that way we can proactively protect the patient's airway. If it's a spinal cord tumor, is this any different from spinal cord injury? So what teaching do you tell the patient? So by the way, this is also different from spinal cord compression as one of the oncologic emergencies. Will it be any different? Same exact idea. So what are the signs and symptoms of spinal cord compression? Okay, so weakness or paralysis. Okay, and then what happens to the bowel and bladder function as well? Then can there be low back pain possibly? We just discussed this also. So same question, similar. What are spinal precautions? Priority will be, okay, and then what else? Can they get out of bed to the bathroom? When we put them on the bedpan, how do we do it?
Push the bed back under while they're flat.
Oh, patient's 250 pounds. How do you slide that in there? Can we log roll? Okay, log roll. The patient having shortness of breath, okay, can't breathe. We cannot elevate the head of the bed.
Yes.
So how do we do? Reverse Trendelenburg, okay? As this is the head, say this is the head, the yellow's head here. So this is Trendelenburg, right? So what is reverse Trendelenburg? This, okay? So this is flat, this is there's semi-Fowlers, okay? That's 30 degrees, semi-Fowlers, high Fowlers.
That's a whole bed moving, right?
With reverse Trendelenburg, yeah, the spine is always straight. Then this is reverse Trendelenburg. Okay? They slide down? No, unless you lube the bed, which we don't. Plus there's a footboard.
How much degree angle is the Trendelenburg when it's reversed?
Reverse Trendelenburg. I mean the bed only goes so much. It can't do that because it'll hit the floor. Okay, so the reverse Trendelenburg is probably 30 or 40, not higher than that, because I mean where else will it go? Okay, because it'll hit the floor already, plus the angle. No, it's about 30 or 40. All right, Parkinson's drugs and their
Reverse is head up or feet up?
Trendelenburg is feet up.
Okay, then reverse is head up.
But remember, the spine is straight, okay? The head of the bed there's no flexion allowed. So no hip or neck flexion is allowed. Parkinson's drugs, so the same drugs we did for exam 3, okay? So yeah, so from levodopa carbidopa to the COMT inhibitors, entacapone, and the dopamine adrenergic agents or agonists, and then you've got the anticholinergics and complications, which is of course the aspiration, most serious complication, and falls, and then skin injuries. So that covers your non-pharmacologic interventions. Yeah, I had a Parkinson's patient die last Sunday. What's today? Tuesday? Yeah, Sunday. Sad. 85. Well, that's not my point. I don't want anyone dying on my ship. They can die on other people's ships. It's difficult, facing the family and then, watching. I don't want to watch that. I mean, I'll take care of them, as until their last thing, but it's different when you see the death, and then the DNR, there's nothing you can do. Let's say they go VTAC. What are you supposed to do? They go, and it happens in a few seconds, and then you see the monitor from VTAC and then the BBCs and then VFib, and then you're just standing there helpless. I mean, you can't do anything. The DNR, DNI. Huh? What are they gonna do? DNR. And you literally watch them die.
Yeah.
But I don't want it, I don't want it. Don't want it happening.
Just
How many deaths you have under your shift?
Huh?
It doesn't record how many deaths you have under your shift.
Well, in my experience, I can only count how many people died on my ship. Yeah, literally, I don't have that many. I can count. I can probably recall all their names.
For the
Yeah.
facility, do they issue a record of that?
Of course, they issue the death certificate. But I mean, for mine, for the people that died on my, I know their names. So I don't have that many. And it's always, with a heavy heart, so you say a prayer, So there's Paul. Oh, I'm sorry, I don't remember the first name of the other one. So at least, one of the names. So here the comparison again between ALS and MS. So similar question as what you had for exam 3. Why are we bothering with rehab for spinal cord injury patients? They're not going to improve. So what are we doing? Okay, they have to learn how to function at their their best functional level. Okay. It's not going to improve it, but so this will be a therapeutic response question. So you're responding to a patient. Yeah, exactly. The patient saying, why am I doing this? And then nurse's best response is, and then another sexual question, bowel and bladder management. This is specifically for preventing which complication? Okay, AD. Emergency management, we did this earlier under head injury, so similar. What's the difference between spinal and neurogenic shock? Oh yeah, we did this also. I remember it was Iviana who read the textbook. So causes, signs and symptoms, and intervention. So what's your first action? Once you identify the manifestations, what are the manifestations? No, that's the cause, manifestations. So on a select all apply, I'll put that, don't pick that, okay? Because the question is signs and symptoms, okay, not a cause. And bradycardia and sweating where? Where's the sweating and goosebumps? Below or above the level of injury?
Level of injury.
Are you sure?
Oh, no way. Everywhere else I can.
Because I heard both above, one said below. Which one?
They only have that sensory response of both.
So what do you do now? You saw it. What do you do? And you position the patient. That's the first action. Set them up and start.
And remove the, and palpate the bladder.
Yeah, because that's the two most common triggers, the bowel or the bladder or the bowel. Don't worry, 9 times out of 10, it's the bladder. So at least you don't have to go digging for gold.
So we don't call for rapid response team or.
We do, because this is emergency. Yeah. Okay, so mechanical ventilation now. What are complications of oxygen therapy? Can they go into toxicity?
Yes.
So how do you prevent that? Do you keep them on high FiO2?
No, we hydrate
Titrate.
for the
For mechanical ventilation, what were those complications we described?
VAP.
VAP number 1, barotrauma, which can lead to a pneumothorax. What else? Yeah, that's VAP. That's number 1. Yeah, pneumonia. Oh, regarding VAP, so how do you prevent VAP? Because this is all about preventing complications. So for VAP,
section, you propose this oral care, at least.
Every 2 hours, and then oral care, and what do we give? What medications is given? Part of the PPI or histamine receptor blockers. How else do we prevent pneumonia? Position will be 30, no, it's in degrees, 30 degrees or 45, but if you're given 30 or 45, which one will you pick? 30, okay, always 30. Okay. Do we routinely deflate the ventilator, the endotracheal tube cuff?
No.
Okay, so we have suctioning. Who picked the suctioning? I think there's still one suctioning procedure left in the box. There's one more in the, because I put 4. Whoever gets it, but there is 16 paper. It's 4.
There was 4, so
That
there was
section
one
is
in
two
there.
skills in 1 hour.
So that means they're all gone.
Oh, God, thanks, bro. Oh, man, so it's
Thanks,
just gonna
guys,
be
I
me.
appreciate you.
All right, so suctioning procedure, don't worry, they don't get it on the skills lab, but everyone will get it on the.
Oh, yes.
What's management for
So what's best practice for first?
pulmonary embolism? Okay, so what's your question on suctioning?
Yeah, what's
Okay.
best practice?
So let's ask the people. So what were the common
Thank you.
um,
So you're really.
no, go ahead. So I mentioned one earlier. So before you, so after insertion, do we apply suction? No, we insert until it comes out of the rectum, right?
No.
We hit mid resistance, and then what? No, you hold back 1 to 2 centimeters. Begin continuous or intermittent? Continuous suction, twirling, and then what do? It's already out. Oxygen, and then rinse. Wait 1 to 2 minutes. Okay, that's okay. So for the intermittent, that was true before. Okay, but all our textbook editions now say continuous. Okay, those are old school people. Okay, so leave them alone. They graduated with that edition of the textbook. Okay, so it's now continuous. Okay, yeah, don't bother. You know, just you can mention. You know, it's now continuous. Yeah, just keep it to yourself, right? And then the ties, the tracheostomy ties.
Let me replace. So you leave it and then.
Put on new ties first and then remove the old ties. Yeah. Okay, that's
Only 2 fingers. One finger.
1 finger.
I thought it's 1
You
or
see,
2 fingers.
1 finger.
Based off the old text.
So it's 1 incorrect. Which one is better, 1 or 2?
Yes, 1.
1.
Okay.
Okay, it should be 1.
Yeah.
That way it's snug.
So what can we find this?
It's on the canvas. I uploaded the skills
You just
procedure.
did that?
No.
We have one to five. We have only for.
1 to 2, yeah, but let's say I put 1. Will you pick that?
And for endotracheal, it's different than for endotracheal. What do you mean?
Suctioning is suctioning.
Oh, because it doesn't have the.
True.
It says suctioning and then it gives you the steps on how to do the skills on how to do the suctioning, but it's give you the step for the care after.
Okay, let's go. It's 1:35.
Yeah.
Managing PE, so mostly drug therapy, right? So in addition to oxygen, it should be anticoagulants. And for massive PE, it will include what? So there'll be questions again on the anticoagulants, so heparin, warfarin, and the novel oral anticoagulants. Lab values, what's D-dimer?
DIC.
It's evidence of what?
Fibrin degradation, DIC.
So what does it prove?
Fibrin degradation.
The clots, the patient has clots. Bleeding times, what bleeding times will we see on the test? PT-INR, PTT. You know which one is which, right? PTT is for? INR, PT-INR will be for? What is for the novel oral anticoagulants? None. Very good. ABG interpretation, same samples we had in class, in skills lab. What's the difference again? Oh, where's Ashley? Oh, she left. What's the difference in the pulmonary edema for heart failure versus ARDS?
Leaking.
Yeah, it's wet, but they're both pulmonary edema.
You would see the whiteout.
Yeah, both will look the same. Put them aside, heart failure patient, pulmonary edema, ARDS pulmonary edema looks the same to me. How do I know?
Oh, the BNP levels.
BNP and what about hemodynamics? Let's say the patient has a pulmonary artery cancer. Or doesn't matter which chamber, right? Right atrial or left atrial pressure, still normal or low. How do we know the endotracheal tube is in the right place?
Yeah.
For X-ray, where should it be?
2 centimeters.
What are your 4 duties when caring for a patient?
And airway, ensure proper oxygenation, ensure proper concentration, secure the airway.
Oh, there's 5 then.
Yeah.
Proper verifying tube placement. So there's 5. What are those numbers to know? Make sure you know the difference between millimeters of mercury and centimeters of water. Can I also use chest rise to confirm placement?
Yes.
Say this is rising. This one is not. Is it in the right place?
Symmetry.
Yeah.
Lung sounds, can I use that to verify placement? Or gastric sounds?
Yeah.
Yes, because if it's in the esophagus, then it will be the belly going up and down. What's the difference between AC and SIMV?
AC is for bad clients and SIMV is for better.
Which one is a volume mode? Both. So since they're volume modes, what's always preset? So how do we distinguish which one is which?
Well, the AC is for patients who can't necessarily control their breathing.
SMV, centralized.
Okay, so therefore in AC, in assist control, also called mandatory, continuous mandatory ventilation, if the patient takes a breath, what will the machine do? It will get the preset tidal volume. In SIMV, the patient takes a breath, initiates a breath. What will happen? The vent will not give the preset tidal volume. Okay, so I don't have the pressure mode here, so I guess I only have questions on AC and SIMV. In ABG, what are those 2 compensatory? Okay, metabolic or respiratory. Again, another prioritization. So this is at least number 4 or 5 already, right? Okay, chest trauma and chest tube questions will be there. Chest trauma, signs and symptoms and management. And then the chest tubes, So the same as in lab. So there's a continuous bubbling on the water seal chamber. What does that mean?
There's a leak.
What do you do then? Clamp for how long? Couple days?
No. Like.
For how long? A few seconds. Okay. Hey, trach suctioning. So this is the second time, right? I know, earlier it was the maintaining airway. Okay. What is FiO2?
What's your S?
Yeah, so in English, what is this referring to? E? Yeah, what is it? Joyce, this is, when we say FiO2, what is this referring to? The percentage, right? Yeah, how much? Let's say 24%, 50%, 100% oxygen. So it's the concentration. Okay, how much oxygen are you giving? A peptic ulcer disease and GI bleeding, we did that. Indications for each blood product. What is packed red blood cells for?
Blood loss.
Anemia. What is platelets for?
Severe thrombocytopenia or.
So who gets it?
As like their antibodies attacking them, supposed to contribute.
That's ITP. So is platelet given to ITP patients? Or because they have antibodies against platelets, so you give them platelets, it'll be useless, right? Yeah. So going back to the original question, who gets a bag of platelets?
Severe thrombocytopenia.
What number is that?
Less than 10.
20. Okay, less than 20,000. About plasma, who gets plasma? Yellow. Who gets plasma? These are all in your textbook. There's an indication for the blood product. Who gets it? Go back to the hematologic chapter. Okay, coagulation factor deficiency. Who are those people who have coagulation factor deficiency? Cirrhosis patients. Who else? What about if I'm taking warfarin? Yes, but my INR is too high, I can get plasma. What if I have Guillain-Barré syndrome?
Yes.
Yeah, he's for plasma exchange, right? What about if I have, oh, that's it. And the rest of these are cirrhosis questions. So we just did that. Your responsibilities for paracentesis, make sure. And what did we say about tips? Is this a last? Why?
Because it couldn't.
What do you do with lactulose? How many do we give?
As many as it can get 2 to 3.
2 to 3 diarrhea?
No.
This one a little bit got lost. Oh no, I put this under skills, right? That's why. Okay. So for ABO, so who gets what blood type?
Oh, universal donor.
Okay, I'll leave you responsible for that. We did this one repeatedly. And then this one we discussed last week for, make sure you check the details, okay? On, let's say, on the prevention, let's say, which one is bloodborne, which one is oral fecal, which one can be transmitted by sexual oral sex as well. See what?
It's when it's highlighted, I can't see it, makes it
Ah.
darker. Oh.
Hepatitis. Reactions, I did not specify which one, so you're gonna have to do all. Okay, so from hemolytic, febrile,
Jolly,
Allergic.
take.
yeah, taco. Yeah, acute lung injury, which is basically gonna be ARDS.
Delay.
Overload, okay, fluid overload.
Overload is taco.
Yeah.
Oh yeah, that's taco, okay. Sorry.
So allergic.
No.
Allergic reaction, bacterial contamination, which is septic.
And delay, yeah.
Okay, so this is also on the skills testing. So what do you do with blood transfusion? So preparing the patient. Do you need consent?
Yeah.
Okay.
Yes, right.
Who's the second nurse that can has to be an RN?
No, can be an LPN.
Can be an LP.
License.
Any licensed professional. Yeah, it should be licensed. So LPNs are licensed.
Sorry.
And then here's the trach again. Oh, central line. Yes, it's been a while since the first week. How do we, what's the frequency?
It's
For what type of dressing? Clear. A clear dressing, 5 to 7 days. Gauze and clear dressing, 48 hours. Here's the Foley. Oh, we didn't have Foley today. It's this semester it's straight, right? Straight catheter.
Yeah.
Sickle cell,
Again, we didn't get to it. That's why I took them out.
so take that out.
Yeah, polycythemia is no longer here, or sickle cell. It's gone.
You need to begin you.
Then that means you printed that before last week.
Give her.
Oh, that was.
And for ACS, the same similar questions, just different numbers or data. Okay,
Oh.
for ACS.
Yeah.